Waiting. Thank you very much for waiting. I just rushed from my home to the studio, and now we are going live from the studio for the session. There was some technical glitch which the IT team could not resolve at my home, so here we are, and we are starting now. So we are looking at biochemistry topics, very important, very relevant for your INICET May 2026, and we'll take a quick look at some of the very likely questions for your exam. So we'll take the questions from previous years, and then we'll talk about the important topic and discuss around that, starting with the first question focused on the Vacutainers. The first question focused on the Vacutainers. Now when you talk about Vacutainers, you have to remember three things. One, first and foremost, is what is known as order of draw, means which tube to be used first, which tube to be used second, and so on and so forth. Second, which tube for which analyte, or rather you can say which tube for which test. So you should know which tube should be used for which test. And the last is which analyte is present in which tube. Analyte means reagent, or in this case, for example, you have the anticoagulant. Anticoagulant is the analyte in one of the tubes. So which anticoagulant or other substance are present in the tube. Okay, so these are three things which you have to know. For example, for HbA1c, we need the lavender top vial. The lavender top vial contains the EDT. Okay, so that is how we are going to quickly talk about the different tubes, the order of draw, and what are the contents in each of the tubes and for which test they are going to be used. So I'm sure all of you know the first one to be used is always for culture study. The first sample to be drawn is always the culture study, so that there is no contamination, there is no false positive in the results that you get in the lab. So if required, always take the sample for blood culture in the beginning. And the important thing to note here is this long neck bottle. The long neck bottle is the one that you are going to be using for the culture studies. Depending on your differentials, the culture media will be different in each of these long neck vials. In each of these long neck vials, the culture media is going to be different. So the first one is always going to be the sample for blood culture studies, followed by the coagulation studies. Second one, a sample to be taken for coagulation studies. Here you use the blue top vial. Blue top vial contains the buffered sodium citrate. Now if you have the pediatric population where you're looking for the coagulation disorders, you might also want to check the platelet function. And when you're looking to check for the platelet function, the component within the tube is actually CTAD. CTAD stands for the citrate, theophylline, adenosine, and dipyridamole. So this is the composition of the analyte within the tube when you also want to do the platelet function in addition to the routine coagulation studies. So first sample for blood culture, second sample for coagulation studies. These are generally not routine tests, but for pre-anesthetic checkup, the coagulation studies is one of the important tests that must be done. Then we go to the third vial in the series, that is the red top vial. You can see there is no gel in this red top vial, and what this vial will give you is the serum. So any test which is performed in the serum, you can collect the sample for those tests in the red top vial. Now previously we used to have the glass vials. The glass vial has a silica. The composition of the glass is silica, so therefore the clot activator is not required when you have the glass vial. However, if you have the plastic vial, then the clot activator is required, because the plastic is not able to activate the clotting cascade. Silica is not there any longer, therefore the clot activator is required, or it can be coated with silica for the activation of the clotting. So here you have to remember the routine biochemical test, for example the lipid profile, the kidney function test, the liver function test, and all the immunological tests. Most of the immunological tests, they are performed in the serum, including the electrolytes. Will be performed within the serum. Okay, so remember the all the tests being performed in the serum. The sample can be collected in the red vial. So if you have any analyte in front of which the serum is written, for example serum amylase, serum lipase, so anything where the prefix is serum, you can collect the sample in the red top vial. Now the red top vial, as mentioned here, doesn't have any gel at the bottom. You know that this gel segregates the clot at the bottom with the serum at the top. The gel will form a barrier in between. So if you have a condition, a scenario where the samples remain untested for some time, the transport occurs later on. For example, you have a lab or a collection center where the collection is happening at 9 a.m. but you dispatch the samples to the lab at maybe 1 p.m. or sample collection is happening at a very distant location, 100 kilometers, 200 kilometers, 300 kilometers away, and then it has to be transported to a centralized testing facility. In those cases, what will happen? The debris from the clot, suppose you have this tube and here the clot formation has taken place and you have this serum which is there. So what will happen? The debris from this clot is continuously getting released. It is continuously getting released into the serum, and it alters the composition of the serum for the analytes which are present in higher concentration within the cell. For example potassium, for example phosphate. These values will rise significantly in the serum and give you the false result. So to avoid this, what we use, the vial with gel. So the additive is similar to what you see in the red vial. The result is similar, you get the serum, but here the gel, it creates a barrier. So you have the tube like this, the gel will form a barrier between the clot and the serum. It will form a barrier between the clot and the serum. Okay, so you can think of this as the gel, and in this way what happens, the debris coming out from the clot is not able to interact with the serum. The serum will rise above the gel and the clot will sink down, so this barrier is created. Here also we are getting the serum only, so whatever test you performed here, the same test can be performed in the gold top vial as well. You can perform the same test. The important consideration is, if the tube remains untested for longer duration, in those cases it is better to have the gel containing tube. If the collection center and the laboratory are side by side, in that case you can use the red vial as well. For some determinations in biochemistry, plasma is required. Okay, so where plasma is required for biochemical testing, we use the lithium heparin as the additive. The common color of the cap is green. You can have either the light green, you can even have the dark green vial. In the dark green vial, no gel is there, otherwise everything is similar to the light green vial. You have the heparin as the anticoagulant, so that you can get the plasma. This plasma can be used for biochemical test wherever they are relevant. There's some special test for which the plasma is utilized for biochemical testing. For example, you can do it for the interferon, etc. So there we use the plasma for the biochemical testing. Now another very common vial is the lavender top vial, which is used for the whole blood hematology, commonly written as the CBC or the complete blood count, The anticoagulant here is EDTA. EDTA is much cheaper than the heparin, and therefore it is a more widely used anticoagulant when you want to do the complete blood count. However, it interacts and interferes with the biochemical testing. So for biochemical testing, we cannot use the EDTA as the anticoagulant, whereas when you want the cells in the intact form, there the EDTA is good enough. It doesn't interfere with the testing. For serum potassium and phosphate, these are tested in the serum. So you can either use the red top vial or you can use the gold top vial for the serum potassium and the phosphate. Any of the two can be used. The consideration whether it will be the red top or the gold top can be determined based on the gap between collection and the testing. If the gap between collection and testing is large, then you prefer to use the gold top vial. However, if the gap between collection and testing is small, your collection center is with the lab, every hour you're sending the samples to the lab, in that case the red top vial is good enough. So main concern is we need serum for doing the potassium and phosphate, and if the sample is kept untested for longer duration, we prefer the gold top vial. I hope that clarifies your answer. All right. So we're talking about the complete blood count, and for this we use the lavender top vial where EDTA is present. Please also note that HbA1c is also estimated in the sample in the lavender top vial, and ESR estimation is also done in the lavender top vial. The ESR previously was being done in sample collected in the black top vial, but now in our country most of the laboratories have shifted to the updated method for testing of ESR, where the lavender top vial is commonly used. For the last few years in our country we are not getting the black top vial, none of the big laboratories are using, so we are mostly using the lavender top vial itself for the estimation of ESR. However, if the question is there, the black top vial is used for which test, in that case you have to mark ESR. Please remember, if the question on black top vial is there, then you will mark ESR. However, on a routine basis nowadays all three of these tests, the CBC, HbA1c and ESR, are being done in the lavender top vial. Then we also have a pink top vial. This also contains EDTA. Here also you get to the free cells are there, coagulation doesn't happen. The lavender top vial and the pink top vial are exactly the same. The only difference is in the pink top vial, the label which is here, the label is different. This label provides provides provision for writing the details of cross matching. Yes, any whole cell based test, whenever you are doing counts, whether it is a retic count where you are doing the total leukocyte count, where you are doing the RBC count, or you are doing the platelet count, all these counts will be done in the lavender top vial. All these counts, whenever you are doing the cell count, it has to be done in the lavender top vial, because these cells should not coagulate. If the coagulation will happen, then the cells will not be in the free form. You cannot identify, you cannot count, you cannot look at the morphology. So whenever you're looking at cells, it has to be the lavender top vial. Okay, so in blood banks we are making use of the pink top vial, which has the special cross match label for patient information for the cross matching. So wherever the throughput of the laboratory transfusion, the blood transfusion in the blood banks is very high, to avoid confusion, in those cases we can use the pink top vial. Please keep in mind, if the pink top vial is out of stock, then pink top vial and the lavender top vial are exactly the same. There is no difference except for the label. Okay, it is only a matter of convenience, but otherwise both of them are containing the EDTA, so you can very well use the lavender top vial. So if the question says in the blood bank routinely the pink vial is being used, however currently the pink vial is out of stock, which is the alternate tube which you can use, so the answer should be the lavender top vial, both of them containing the EDTA. And then another very common tube which is used, the gray top vial, for estimation of plasma glucose containing potassium oxalate with sodium fluoride, or the EDTA with sodium fluoride. Please note, in this case, when we are collecting the sample for estimation of plasma glucose, one factor is sodium fluoride. Sodium fluoride is required. The sodium fluoride is required for the inhibition of glycolysis. It is acting on the enolase and it blocks the glycolysis, right? However, sodium fluoride is a weak anticoagulant and therefore it is always mixed with strong anticoagulant. It is always mixed with the strong anticoagulant. Previously the anticoagulant used to be potassium oxalate, but nowadays if you look at the gray vial, most of the gray vial will be having the EDTA. Most of the gray vial nowadays will be having the EDTA. So you should have to remember, in the gray top vial, sodium fluoride, yes, but along with that you must have the strong anticoagulant. It can either be the potassium oxalate or it can be EDTA. Sodium fluoride alone is not enough. It must be mixed with the strong anticoagulant. Okay, so for blood alcohol level, yes, you can use the lavender top vial. Again for the blood alcohol level you can use the lavender top vial, right? Also remember, I told you the dark green vial also contains the heparin and therefore it can also be used for plasma contamination of biochemistry. Difference being, here the gel is not there. In the light green vial the gel was there. And in rare cases you might come across this vial having the royal blue cap. This royal blue cap vial is used in forensic laboratories. The reason being, this cap in this vial is having special treatment. So it is used for identifying trace element, toxins, nutritional deficiencies. All of these can be estimated in sample collected in the blue top vial. Here what we have is specially treated rubber barrier. All micro elements are removed. So whenever you're looking for trace elements in forensic laboratory for medical legal cases, it is ideal to collect in the dark blue top vial. However, it is not routinely available, and for all practical purposes, depending on the test which is required, either you can use the red top vial, or if you're looking for plasma, then you can use the either the heparin or the EDTA containing vial. Okay, but ideally for forensic purposes, for medical legal cases, we are looking for trace elements or nutritional deficiencies or toxins. In those cases it is best to use the dark blue or the royal blue cap vial. So this is about the order of draw, which test in which tube and which analyte within which tube. These are very, very important questions which you have to know. Yes, you can use the green vial for ABG because it is having the heparin, also for immunophenotyping. HLA matching, yellow, yes, you can do that. Blood alcohol is gray. Okay. For HLA matching, I'm not sure. I'll cross check the question on HLA matching and get back to you. Okay, then we go to the next topic, next very, very important topic, and that is very, very simplistic but very commonly repeated question in the exam. That is the thermic effect of food. The thermic effect of food is sometimes also known as the specific dynamic action. It is also known as the specific dynamic action. Essentially what it talks about, is the percentage energy required for metabolism. It is mainly talking about how much energy is required for the metabolism, how much energy is required for metabolism. So we have a very simple, you can say, percentage values for each of these, which you have to keep in mind. And for carbohydrates, the energy required is lowest. They are very easy to digest, and the amount of energy required is 5 to 10% of their own calorific value. For the okay, this is incorrect. For amino acids and proteins, it is 20 to 30%. For amino acid and proteins, 20 to 30%, and for lipids and fatty acid, it is about 10 to 15%. It is about 10 to 15%. So if you have to write one value, in that case you use the values as 5, 30 and 10. 5, 30 and 10. Okay, so you can make out that the highest thermic effect of food is for amino acids and proteins. Blood alcohol is routinely done in the gray vial. It is routinely done in the gray vial. Some laboratories do collect in the red top vial also, but most commonly it is collected in the gray vial. The idea being that the fluoride which is there can also act as a weak antimicrobial agent. So more commonly it is collected in the gray vial. So if you have to choose one, then the gray vial should be the best answer for blood alcohol, although some laboratories do collect sample in the red top vial as well. Okay, so thermic effect of the food, very important, also known as the specific dynamic action of the food, and I told you it is representing the percentage energy required for the metabolism for that particular type of food. And the highest thermic effect is for the proteins. Highest thermic effect is for proteins. As we saw, approximately 30% is the SDA for the proteins. Then another very simple question regarding the percentage of the different food as contributors to the energy. How much energy should come from which type of food? So that is a very important topic, and the term used is the balanced diet. The term used is the balanced diet. So as per National Institute of Nutrition, ICMR, the about 50 to 60% of the calories should come from carbohydrates, about 10 to 15% of the calories should come from proteins, and about 20 to 30% of the calories should come from fats. Please note, very important, up to 30% of the energy should come from fats. However, we keep hearing, no, you should eat less fat, you should eat less fat. What you have to keep in mind is the fat that we are talking about is actually of two types. One is the fat or the oil which you use for cooking, or for, you can say, making it more palatable. For example, you are applying some butter on the toast, so that is the fat that we commonly use for preparation of the food. You use oil for the cooking. So these are the visible fat, but all the food stuff also contain some fat which is called the invisible fat. Together these two should be 20 to 30%. In other words, the amount of fat that you are going to be adding from the top should be in the range of 8 to 10% as the source of the energy. And that is where the dietary advice for limited consumption of fats comes, because most of your food is already having some amount of fat, and if you add a lot of fat from outside, then these values will become very high. So please keep in mind, up to 30% of the lipid content in the food is part of the balanced diet. Up to 30% of the lipid content in the food is part of balanced diet. Only when the value crosses 35%, we will call it the high fat diet or the lipid rich diet. So please remember this point, up to 30%, up to 30% is normal. Up to 30% fat content in the food is normal. Okay. Now, very important, very commonly and most frequently repeated question in your exam will be the question on the acid base disorders, where you get the result of the ABG analysis, arterial blood gas analysis results are available. Very frequently arterial blood gas analysis results are available, wherein you get the values of the pH, you get the values of the PCO2, you get the values of the bicarbonate concentration, and you also get the value of certain electrolytes through which you can measure what is known as anion gap. Okay, so these are the values that you can calculate or you get on the arterial blood gas analysis. As you know, the normal value for pH is 7.35 to 7.45. The normal value for PCO2 is 35 to 45 millimeter of Hg. Please note there are no units for pH, no units for pH, and 35 to 45 millimeter of mercury for PCO2. For bicarbonate it is 22 to 26 milli equivalent per liter. Units are very important. For anion gap the value is 8 milli equivalent per liter. These are the normal values which you have to keep in mind. Okay, now when you look at these values, very commonly you will be asked to talk about the diagnosis based on the results that you get for these values. All right, so the question which is routinely asked is interpretation of the ABG values. Based on the ABG values, you have to interpret the type of acid base disorder. Okay, so what you have to keep in mind is when there is acidosis, when there is acidosis there are two possibilities. Acidosis means the H plus concentration is higher. H plus concentration in the blood is coming from PCO2. That means either the PCO2 value should be high. The other aspect is H plus value can be relatively higher when the bicarbonate value is low. So the other way in which the H plus value can rise is if the bicarbonate is low. So when we talk about acidosis, what you have to remember, in acidosis either the PCO2 will be high or the bicarbonate will be low. Correspondingly, when we talk about alkalosis, the inverse will happen. What do you mean by inverse will happen? Either the PCO2 value will be less, PCO2 is the contributor of H plus, or the bicarbonate value will be higher. Okay, so based on whatever finding that you get, you can make the primary diagnosis. For example, let's say you get the pH here of 7.34. 7.34 means you're looking at acidosis. Now when you're talking about acidosis, either the PCO2 should be high or the bicarbonate should be low. Now look at the values. What about the bicarbonate value? What about the bicarbonate value? Is it low or high? Normal value is 22 to 26 milliequivalent per liter, and here the value is 20, so it is low. That means your primary diagnosis is identified, the condition which is matching your prediction. This will be your primary diagnosis. That means we are looking at metabolic acidosis. So alkalosis parts you can delete. We are looking at metabolic acidosis, right? Now whether the anion gap is normal or high, whether the anion gap is normal or high, you can calculate by the very simple formula, that is measured cations minus the measured anions. Now routinely for your formula, the measured cation will be sodium and measured anions will be chloride and bicarbonate. So if you replace the values from the given question, That means the value of sodium is 135, the value of chloride is 93, the value of bicarbonate is 20, which gives you 135 minus 113, which is roughly 22, right? So you're getting 22 milliequivalent per liter as the anion gap, and we said normal anion gap should be 8 milliequivalent per liter. So obviously it is a high anion gap metabolic acidosis, like most of you have already mentioned that the high anion gap metabolic acidosis, HAGMA, is the correct answer, right? High anion gap metabolic acidosis is the correct answer. Very good. The anion gap in this case is 22, and therefore it is a case of high anion gap metabolic acidosis. Here, like Animesh is saying, you should also know about compensation. So the compensation part is very, very simple. See, we just mentioned that depending on which parameter matches our prediction, we identify the primary cause. So in this case, because the bicarbonate component was found to be low, the primary diagnosis is that we are looking at metabolic acidosis, right? Now, when you look at the PCO2 value, there are two possibilities. It is not increased, right? Otherwise the primary diagnosis would have been the respiratory acidosis. So PCO2 is not increased. Then there can be two possibilities. One, it is normal. Second, it is going in the opposite direction. We expected it to be high, but it is low. If it is normal, then there is no compensation. Compensation is not there if the value is normal. So in acute cases there will be no compensation, and the value of the second parameter will be in the normal range. However, if the value of the second parameter goes opposite to what you expected the PCO2 value to be high, but here the PCO2 value is less, then this is the respiratory compensation. When the value of the parameter goes opposite to what you expected, then there is a component of compensation. Whenever the chronic conditions will be there, in those cases you're going to see the compensation, right? So please keep in mind, compensation is seen in chronic cases, and the parameter will go opposite to the expected value in the given condition. So in acidosis, the bicarbonate should be low. If it goes high, then it is metabolic or renal compensation. Similarly, if PCO2 is supposed to be high and it goes low, then it is a respiratory compensation. The same thing will be there in alkalosis. You expect the PCO2 should be low, but in alkalosis you find that PCO2 value is high. That means the kidney is trying to compensate. So compensation is the parameter going opposite to what you expected. So you can use this very simple flow chart to identify the primary diagnosis and look at the compensation. So first you look at the pH. Based on the pH value, you determine whether it is less than 7.4, it is more than 7.4. If it is less than 7.4, in that case you say that okay, it is acidosis. If it is more than 7.4, then you say okay, this is alkalosis. Now in acidosis, we already said either the bicarbonate value should be low or the PCO2 value should be high. Whichever matches your prediction is the primary diagnosis, right? Whichever matches your prediction is the primary diagnosis. However, in some questions, additional value for the second parameter in the opposite direction can be given, in which case you have to also mention the compensation. If the options talk about compensation, then you need to look at the second parameter and see whether it is in the normal range or it is going in the opposite direction. Okay, so you can use this very simple flow chart to identify what is the primary diagnosis and whether the compensation is there or not. Also, sometimes you might get this chart or diagram in your exam. This is known as the Davenport diagram. This is a very simple tool to use in emergency situations for simple acid base disorders. It will not work for complicated acid base disorders. It will not work for complicated acid base disorders. So the Davenport diagram can be a simple tool to identify acid base disorders. Here you have to be very careful about one of the parameters. As you can see, on the x-axis you have the arterial blood pH, on the y-axis you have the arterial plasma bicarbonate values, but on the remaining two dimensions. There is the value of pCO2, and the very important thing to note here, very important thing to note here, that the value of pCO2 is not plotted on a straight line. For example, if 40 is written here, the value of pCO2 is not along this straight line. Please keep in mind, it is not along this straight line. Where is it present? It is present along this curved line. It is present along this curved line. So when you get this diagram, when you're plotting the values, let's say in your ABG analysis the value of pCO2 is given as a 30, then the 30 will not be plotted here. No, 30 has to be plotted along this curved line. 30 has to be plotted along this curved line, and that is how you have to read out the corresponding values. That is how you have to read out the corresponding values. So please be very careful about the third factor, that is pCO2, how to plot it on that Davenport diagram. X and Y are simply following the arterial blood pH and the arterial bicarbonate values, but pCO2 value is slightly tricky. So please be careful when you are looking at the Davenport diagram. Now sometimes you can have the question for the high non-gap metabolic acidosis conditions as a straightforward question. What you have to understand when we talk about the metabolic acidosis, we have two conditions. One is the normal anion gap metabolic acidosis, second is the high anion gap metabolic acidosis. Very characteristic conditions where the high anion gap is seen, but the underlying concept is very important. You will get to see the high anion gap metabolic acidosis when there is increase in production of acid, or there is very high ingestion of acid. Okay, when there is very high ingestion of acid, in those cases you are going to see the high anion gap. So what happens? The H plus component contributes to the pH. The anion which is now present in the blood is unmeasured. Please remember that the blood is always neutral. There is no charge. There is no charge in the blood ever. So the amount of cation, amount of anion is always equal, and when you look at the difference, it is 0. But the trick is, we are not measuring all the cations, we are not measuring all the anions. We are only measuring the sodium for cations, and we are only measuring the chloride and bicarbonate for the anions. Right? For all of this we are not measuring. So if these unmeasured anions increase, there will be a corresponding decrease in the concentration of the measured anions. And when you look at the difference between the measured cations and anions, the cation is still the same, the amount of sodium is still the same, but the bicarbonate and chloride have relatively decreased. Therefore you will find the increased anion gap. So whenever there is production or ingestion of acids, then you are going to have the high anion gap metabolic acidosis. Some of the very important causes for the high anion gap metabolic acidosis can be remembered by the very simple mnemonic cat mud piles. Even out of this list, the mud piles part is more commonly seen. But to make it exhaustive, I have written the cat part, which is also the causes for high anion gap metabolic acidosis. Okay, so you can see the methanol toxicity, uremia, whether it is due to acute or chronic kidney condition, the ketoacidosis, whether it is diabetic ketoacidosis, it is due to alcoholism, or it is due to the starvation. Any ketoacidosis is also causing the high anion gap metabolic acidosis. P for paracetamol, fenformin, paraldehyde, and polyethylene glycol. Here I would like to mention that whether it is the polyethylene glycol, or it is simply the ethylene glycol, or it is the diethylene glycol, any of the ethylene glycols are going to cause the high anion gap metabolic acidosis. Recently, if you remember, in one of the cities in Madhya Pradesh, we had this episode where a series of children were getting sick. Some of them even expired due to consumption of the cough syrup, which was spiked with the diethylene glycol. Okay, so please remember this ethylene glycol as an important cause for the high anion gap metabolic acidosis. For I, in addition to isoniazid and iron, you have to remember the inborn error of metabolism. So most of the inborn error of metabolism are producing additional metabolites which are acidic in nature, and therefore in these conditions you are going to get the high anion gap metabolic acidosis. Lactic acidosis of any cause, lactic acidosis of any cause is also going to cause the high anion gap metabolic acidosis. Okay, the two conditions, renal tubular acidosis type 1, 2 and 4, and the diarrhea. These are the two important causes for normal anion gap metabolic acidosis. Okay, the normal anion gap metabolic acidosis commonly seen in renal tubular acidosis and diarrhea. In diarrhea, what is happening? The base part, the bicarbonate is getting lost. The bicarbonate is getting lost in the stool, and therefore it is causing the acidosis. Okay, all right, so that's about the high anion gap metabolic acidosis. Remember, in this case you can either get the direct question, or sometimes you can get a clinical scenario where they give one of these conditions. They will tell you by pH that the acidosis is there, and they'll not give you the values of the PCO2 and bicarbonate, and subsequently ask you whether it is the metabolic acidosis or metabolic alkalosis or respiratory acidosis or respiratory alkalosis. So whenever you see the conditions listed here, please remember all of them are going to be associated with the high anion gap metabolic acidosis. Acidosis part is the important component that you have to remember here. So like we said, the inborn error of metabolism, diabetic ketoacidosis, renal failure, all of them will cause the high anion gap metabolic acidosis. Diarrhea will cause the normal anion gap metabolic acidosis. The diarrhea is going to cause the normal anion gap metabolic acidosis. Okay, now we come to some of the very important vitamins which are routinely asked in your exam, about which you must know, and the most important in this list is B1. So here you see the question of Korsakoff psychosis, what is true, and you have a list of clinical features which are which might be seen, and you have to choose which all will be seen in Korsakoff psychosis. Now when we talk about the B1 deficiency, you have to remember it is commonly seen in chronic alcoholics, and the two common conditions that you see due to the B1 deficiency, one is the beriberi. You can have the symptoms of the neurological systems when we call it the dry beriberi. You can have the symptoms of the cardiovascular system when you call it the wet beriberi. You very frequently have symptoms from both the systems. Okay, the second one is the Wernicke's encephalopathy, and I'm sure most of you know the features of Wernicke's with the help of the mnemonic GOA: global confusion, ophthalmoplegia and ataxia. Okay, so these are the features of Wernicke's encephalopathy. However, if Wernicke's encephalopathy stays untreated, gets exacerbated, and that is when the Korsakoff psychosis sets in. So remember, the features of Korsakoff psychosis are added upon the features, they are added upon the features of Wernicke's, they are added upon the features of Wernicke's. So whenever you have Korsakoff psychosis, this GOA part will always be there. The features of psychosis are over and above the features of Wernicke's encephalopathy, right? So the ophthalmoplegia will definitely be there when you're talking about the psychosis. When you're talking about the psychosis, the ophthalmoplegia will definitely be there. The amnesia and confabulation, these are the specific features of psychosis, correct? 1 and 2 are specific features of psychosis, but it will also have the backdrop of global confusion, of thalmoplegia and ataxia. Okay, so among the given list, as you can see, the best answer is 1, 2 and 3. All right, so like I said, Wernicke is seen in chronic alcoholics, global confusion of thermoplegia along with ataxia is seen. When psychosis is present, then amnesia and confabulation are the additional features. Okay, these are the additional features. But if we can clean the question, the ataxia part may not be mentioned if the clinical case is there. For ataxia, they can write that positive nose finger test. What is nose finger test? You ask the patient to bring his finger, tip of the finger, to his nose. In patients of ataxia, he is not able to do this touching of the nose with the tip of the finger. He'll take the finger to his eyes, he'll take his finger to the mouth, to the chin, he'll take it everywhere except for the tip of the nose. Another common test for ataxia can be the walking in the straight line, the straight line test. You ask the person to walk on a straight line on the ground. The person will go to the left, come back to the line, go to the right, come back to the line, but not be able to walk on the straight line. So positive straight line test or the positive nose finger test is indication for the ataxia. Okay, about the amnesia, it is typically the short-term memory loss. Sometimes the examiner can make it interesting by mentioning long-term memory loss, but generally it is the short-term memory loss. The anterograde amnesia is there. The retrograde amnesia is generally not seen. The long-term amnesia is generally not seen. Okay, so that was about the vitamin B1. Very commonly we get the question on beriberi and the Wernicke's. About the beriberi, one important thing that I would want to tell you, that in the wet beriberi, there is this characteristic finding of high output cardiac failure. High output cardiac failure is a very characteristic feature which will be mentioned in the wet beriberi. What you have to understand here is the clinical presentation will be that of heart failure, easy fatigability, edema of the limbs, so like that things can be in there, breathlessness on walking, those things indicating the heart failure will be there. But when you send such a patient for the echocardiography to look at the ejection fraction, commonly you think when the heart failure is there, ejection fraction will be low. To confirm that the cause is yes cardiac in nature, you send the person for the echocardiography. But while you do the echocardiography, in these patients you expect the ejection fraction to be decreased. The ejection fraction is paradoxically increased. So you have the features of cardiac failure, but along with that the cardiac output is high. We call this the high output cardiac failure. So if the term high output cardiac failure is given or it is described in the question, then you know you're dealing with beriberi. That means the vitamin B1, also known as thiamine deficiency, is what we are talking about. Okay, so remember, thiamine deficiency commonly seen in chronic alcoholics, associated with beriberi and Wernicke's. In beriberi, sometimes you can find this characteristic term, the high output cardiac failure. For Wernicke's, we have the three classical features: global confusion of thalmoplegia and ataxia. If it progresses further, can be complicated with the Korsakoff psychosis, which is associated with amnesia and confabulation. Amnesia is commonly short-term amnesia in nature. Long-term memory loss is generally not seen. Okay, now what you have to understand, that a lot of vitamins are involved in lots and lots of reactions, the metabolic reactions, and the product of these metabolic reactions are commonly involved in synthetic pathways. One very important example is the conversion of the UMP into the TMP. The enzyme catalyzing the reaction is the thymidylate synthase. And for this reaction, the methylene tetrahydrofolate is required. In the reaction, it quickly gets converted to dihydrofolate. Dihydrofolate is recycled to tetrahydrofolate, and tetrahydrofolate then gets converted back to the methylene tetrahydrofolate. All right. Now imagine if the tetrahydrofolate is not there. If the tetrahydrofolate is not there, in that case the reaction will get blocked. So now the thymine cannot be formed. The thymine cannot be formed because the tetrahydrofolate is not there. And therefore, wherever the thymine was going to get incorporated, instead of thymine, the uracil will start getting incorporated. So misincorporation of uracil into DNA will be seen in deficiency of the folate. It will be seen in deficiency of folate. And this folate deficiency can be actual or it can be functional. Functional means you see folate deficiency in case of folate trap also. So if the folate part is not mentioned, then the vitamin B12 will cause a folate trap. So functional folate deficiency will be there, and then again you can see the misincorporation of uracil into the DNA. Okay, so remember this point, that the exact mechanism is folate deficiency. Folate deficiency can be actual or it can be functional folate deficiency, which we see in case of B12 deficiency, right? So please keep this point in mind, that when the tetrahydrofolate deficiency is there, conversion from the UMP to TMP cannot occur effectively, and therefore misincorporation of uracil can be seen into the DNA. Please also remember that the thymidylate synthase is a common target for chemotherapy. The 5-fluorouracil is acting on thymidylate synthase. The dihydrofolate reductase, which is acting into the conversion of dihydrofolate to tetrahydrofolate, is also a common target for chemotherapy. The drug being used here is methotrexate. These are additional commonly asked questions which you should remember. Okay, another very important and commonly asked question is talking about distinguishing between the folate deficiency and the B12 deficiency. In this question, what you can see, 24-year-old female presents with low hemoglobin, anemia is there, easy fatigability, and therefore along with that you see the tingling sensation in hands. This is hands and feet, in hands and feet, along with altered proprioception. So what you are seeing here, you are seeing two things. One, you saw anemia, plus you are also seeing the neurological features. All right, what else is mentioned in the question? She was treated with folate supplementation because about anemia, it was seen the peripheral smear, the megaloblasts are there, so treatment with folate is there, which will help resolve the anemia. But if this is due to folate trap, the anemia will improve. However, the neurological symptoms will worsen because whatever B12 is there, it will be directed towards recycling of the folate, and the neurological activities will be lost. All right, so in this case the neurological features will get exacerbated, and this is in case of B12 deficiency, folate trap, or in other words we are actually dealing with the B12 or the cobalamin deficiency rather than the folate and deficiency. So here two things to note. In B12 deficiency, the common feature is methylmalonic aciduria, which is commonly given in the question when you're talking about the B12 deficiency. The pernicious anemia is seen, which has two components. One is the megaloblastic anemia due to the folate trap, and second is the irreversible degeneration of the spinal cord, commonly written as the SCD or SACD, the subacute combined degeneration of the cord. Please note that this is the irreversible degeneration of the spinal cord. Okay, so these are the very important features of the B12 deficiency, and this is how the megaloblastic anemia will be seen. The large red blood cell is there, and the hypersegmented neutrophil. In the microscopic image you can see the appearance like this. The hypersegmented neutrophils are there. I'm sure you know that hypersegmented neutrophilia will be described when you have 5 or more 5-lobed neutrophils per high power field, or even one 6-lobed neutrophil per HPF. In those cases we call it the hypersegmented neutrophilia. We call it the hypersegmented neutrophilia, which will be feature of both B9 and B12 deficiency. B9 because it is due to the folate actual deficiency, B12 because it is due to functional folate deficiency. SQ9OM, which vitamin you are saying? It's just why not B question mark? Which B? B9, B12, B6, which one are you talking about? B as an option question, option B, unmasked pyridoxine deficiency. Pyridoxine is vitamin B6 and it doesn't have anything to do with the folate. Okay, pyridoxine is B6, it doesn't have anything to do with folate. If you're talking about the B12, then it is cobalamin, not pyridoxine. Pyridoxine is vitamin B6. Okay, here very quickly I'll help you to distinguish between B9 and the B12 deficiency, because they can have some common features. However, you will be frequently asked to distinguish between these two conditions. So the common features will be, number one, the megaloblastic anemia. Along with megaloblastic anemia, you find the cysteine levels are elevated. So either homocystinemia or homocystinuria can be there, and in these cases, due to the actual folate deficiency, you will have megaloblastic anemia and homocystinuria, and due to folate trap, the same features will be seen in the B12 deficiency as well. However, the methyl malonic aciduria and the subacute combined degeneration of the cord, these are not seen in B9 deficiency because they are the characteristic features of the B12 deficiency. They are not seen in B9 deficiency because they are the characteristic features of B12 deficiency. Okay, so this is how you can distinguish between B9 and B12 deficiency. For example, question says you find a patient with anemia on peripheral smear examination, the megaloblasts are there, homocysteine levels are elevated, but methyl malonic acid levels are normal. When I say methyl malonic acid levels are normal, I'm talking about the B9 deficiency. But if I say methyl malonic acid level is also elevated, then I'm talking about the B12 deficiency. So just by looking at this table, you are able to distinguish between clinically presenting B9 and B12 deficiencies. The SCD and SSCD will typically present with the peripheral neurological features which were mentioned in this question: the altered proprioception, tingling sensation in hands and feet. So all of these are features of the peripheral neuropathy which will be seen due to the damage in the spinal cord. Commonly the features resemble the upper motor neuron lesion features. Commonly the features are like the human lesions. Okay, so that's about the B9 versus B12, very commonly seen. Now we go to another very important topic, and that is the glucose uptake by the different tissues. Okay, and most frequently repeated question is where you see the insulin dependent or the insulin independent glucose transport. So actually the question is wanting to ask about glucose uptake which is dependent on insulin. That is what is asking. All cells show glucose uptake independent of insulin except, all right, so in other words, in which tissue the glucose uptake depends on insulin. All right, so here you have to remember the adipose cell and muscles. Let's quickly take a look at the table where it shows how the transport of the glucose is happening with the help of the transporters. So in this context, all of you know that we have two types of transporters. The first being the facilitative bidirectional transporter is known as the GLUT series. The GLUT series is the facilitative bidirectional transporter. You have 14 subtypes of the GLUT series are there, but the most important ones being GLUT 1, 2, 3, 4 and 5. The second category is the sodium dependent unidirectional symporter. Symporter means it is transporting two analytes simultaneously in the same direction. You have the SGLT1 and SGLT2. We have the SGLT1 and the SGLT2. Okay, quick look at each of these. First, the GLUT1, it is responsible for basal transport and it is commonly seen in all tissues, for basal metabolism. The important point to remember is erythrocytes have only GLUT1. All other tissues will have GLUT1 plus something else. For example, if you look at liver or you look at the kidney, or you look at the intestine, you can see here kidney has GLUT1, but kidney also has GLUT2, kidney also has GLUT3. So most of the tissues will have GLUT1 plus something else, except for RBC. RBC has only GLUT1. This is another very commonly asked question. Then about GLUT2, what you have to remember is it is responsible for the rapid uptake and release of the glucose. So wherever rapid transport is required, in the liver, in beta cell of pancreas, in the small intestine, and kidney, we have the GLUT2. GLUT3 is having the highest affinity. It is having the highest affinity for the glucose, and therefore in tissues which are surrounded by low concentration of glucose, brain surrounded by CSF, concentration of glucose in CSF is 2/3 that of blood. Similarly, in the renal medulla, you get the venous blood from the vasa recta, so it has a low glucose concentration. Same goes for placenta, and here you can add the cancer cells. Even in cancer cells, the GLUT3 must be active, and we use this property of the presence of active GLUT3 in cancer cells in PET scan to identify cancer cells. The F18 labeled glucose is used, and wherever you find higher or faster uptake of the F18 glucose than normal, those will indicate the cancerous cells. Okay, so GLUT3 highest affinity, therefore it is useful in scenarios where the concentration of glucose in the surrounding tissue is lower. Now coming to GLUT4, the GLUT4 is very important. GLUT4 is responsible for insulin stimulated glucose uptake, So basically what happens is you have this tissue. Within the tissue, on the vesicles, we have this transporter called the GLUT4. The GLUT4 will be mobilized when the insulin will come. When insulin levels rise, that is when the GLUT4 is getting mobilized. The GLUT4 is getting mobilized to the surface, and once it is mobilized, it will start taking up the glucose molecules. Okay, so mobilization of GLUT4 is done by insulin, and this GLUT4 is present only in the muscles, whether it is the cardiac muscle or the skeletal muscle, and in the adipose tissue. These are the only places where the GLUT4 will be present. What this also means, when there is overnight fasting, the insulin level will fall, right? When insulin level will fall, the signal to the cell will also fall, and the transporter will go back inside. So this is another very important question. After overnight fasting, the concentration of glucose transporter is reduced on which tissues? Wherever GLUT4 is present. Wherever GLUT4 is present, in those tissues the concentration will be decreased. So please remember, after overnight fasting, concentration of blood of the glucose transporter is decreased in the muscles, the skeletal muscle, the cardiac muscle, and the adipose tissue. Very commonly repeated question. Also note, the vesicles can be mobilized by calcium as well. Therefore, for type 2 DM patients where the insulin stimulus is not provided due to the insulin resistance, we tell them to do vigorous physical activity. When they do the physical activity, the calcium will be released in the skeletal muscle, and this GLUT4 is present in the skeletal muscle. By the action of calcium, the GLUT4 will be mobilized to the surface. It can start taking up the glucose. The glucose levels will fall. So please remember that calcium can also mobilize the GLUT4 in addition to the insulin, and that is the basis for recommendation of the vigorous physical activity in type 2 DM patients where the insulin resistance is seen. All right. So that's about the GLUT4. About GLUT5, we have to remember it is the only transporter which can take up fructose from diet. On the luminal surface, we have the GLUT5 and the SGLT1. Okay, on the luminal surface we have the GLUT5 and SGLT1. The SGLT will take up only glucose and galactose. It doesn't take up fructose. Please remember, the SGLT will transport only glucose and galactose. It will not transport the fructose. So fructose uptake from diet is mediated exclusively by the GLUT5. Now talking about the SGLT, we have two types, SGLT1 and SGLT2. SGLT1 is primarily present in the small intestine. SGLT2 is exclusively present in the kidney. SGLT2 is exclusively present in the kidney, and that is why SGLT2 is targeted for inhibition, for decreasing the glucose level. So after filtration, the glucose has to be absorbed by the action of SGLT2. If you block the SGLT2, glucose absorption will not take place. So gliflozin, the new class of drugs, the dapagliflozin, empagliflozin, so these are the drugs which are SGLT2 inhibitors. Okay, SGLT2 primarily present in the kidney, and it prevents, when you block it, the reabsorption of glucose will start getting affected. Glucose levels can fall in patients of type 2 diabetes mellitus. All right, going to the very common another question, that is the glycogen storage disorders. Another very common question and you should know the name of the enzyme for the specific condition. So this table I've given to, yes, the gliptins, no, not the gliptins, the gliflozins, the dapagliflozin, the empagliflozin. So those are the SGLT2 inhibitors. Okay, so the enzymes for the specific glycogen storage disorders is another very common commonly asked question. Sometimes it can be given in the form of clinical case as well. So I'll briefly talk about the clinical features of the different types of the glycogen storage disorders also. Let's first match the enzymes. Cory's disease associated with branch structure in liver biopsy. Okay. McArdle disease, accumulation of McArdle's exercise intolerance. The Pompe's disease, accumulation of glycogen in lysosome. In von Gurk's disease, hypoglycemia, severe hypoglycemia with lactic acidosis. So 1A, 2C, 3B and 4D. Okay, C option is somewhat wonky, but option D is the correct answer. So the points which you have to keep in mind, first is this table about the enzymes. Please note, in type 1 von Gurk's glucose 6 phosphatase is deficient. We also have a type 0 where glycogen synthase is deficient. So in type 0, what will happen? No glycogen stores. There will be no glycogen stores in these patients. Okay, going to the type 2 Pompe's, the lysosomal glucosidase, also known as acid maltase. The enzyme is lysosomal glucosidase or acid maltase. In type 3, we have the Cory's disease where the D branching enzyme is deficient. Type 4, we have the Anderson disease where the branching enzyme is deficient. Type 5, McArdle's, where the muscle phosphorylase is deficient. Type 6, generally not asked, Hirsch's disease, where the liver phosphorylase, also known as the hepatic phosphorylase, is deficient. You can use a simple cantrip, C followed by D. For in Cory's, the D branching enzyme is deficient. In Anderson's, the branching enzyme is deficient. In McArdle's, the myophosphorylase is deficient. In Hirsch's, the hepatic phosphorylase is deficient. So you can use this cantrip to remember the enzymes for the type 3, 4, 5 and 6. In type 3, that is C. Cories, the D branching enzyme is deficient. In type 4, in Anderson's, the branching enzyme is deficient, A followed by B. In McArdle's, M followed by M for myophosphorylase, and in Herd's, H followed by H, that is for the hepatic phosphorylase. So first, the enzymes in the different clinical scenarios. Second, about von Gerke's disease, what you have to remember is there is very severe hypoglycemia, and this very severe hypoglycemia can give rise to fainting episodes. So another important feature is a fainting episode. In the question, sometimes they can also mention hyperuricemia, and they can use the term doll-like facies due to deposition of fat by frequent feeding by the parents. In these patients, the children are very irritable in between the meals. So to overcome this tendency for irritation, the parents learn that okay, becoming irritable because they want food, they are having hypoglycemia, so they feed them very frequently. But the fallout of this frequent feeding is lots and lots of fat synthesis occurs in the body, deposited all over the body, over the face also. So the face becomes completely round like a doll due to deposition of the fat. This is called the doll-like facies, common feature in von Gerke's disease. The doll-like facies is a common feature in von Gerke's. In Pompe's, what you get to see is the multi-organ involvement, and very characteristic is cardiomegaly, and this cardiomegaly is also the cause of death. So you may even get the X-ray picture where it shows the cardiomegaly. They can mention that there is failure to thrive and other features are there, but the cardiomegaly is seen and either early death is mentioned, or later on they can mention that one of the siblings died early. Just like we have multi-organ involvement here, in von Gerke's disease you have the liver and kidney enlargement. Liver and kidney are enlarged in the von Gerke's disease. In type 3, where you have the D branching enzyme deficiency, what you find, very high number of branches. This is what we had mentioned in the question as well. If you see Cory's disease, branched structure in liver biopsy. Okay, so very high number of branches in the branching enzyme. One characteristic description which is there, fasting hypoglycemia. The linear part degraded by the phosphorylase, right? But when you reach the branch positions are resolved by the debranching enzyme. So as long as the linear parts are being broken, the hypoglycemia will not happen. So in the post-fed state, the hypoglycemia is not there. But when it comes a turn to break the branches, the debranching enzyme is not there, and that is the time when we have reached the fasting stage. So you get the fasting hypoglycemia. But the story doesn't stop here. The fasting hypoglycemia is unresponsive to administration of glucagon. So this is mentioned in the question that in after feeding, if you give the glucagon, glucose levels rise, but in the fasting state, when you give the glucagon, the glucose level does not rise. So non-responsive to glucagon administration in the fasting state. Okay, in that is the very characteristic description which will be there for the Cory's disease. Okay, yeah. The Anderson is commonly not asked. Here you have poorly branched glycogen. Please note, sometimes in the question they will mention that normal glycogen stores are there, normal structured glycogen stores are there. Now here you see high number of branches, and here you see very low number of branches. So these two are abnormal glycogen. If the question mentions glycogen with normal structure, in that case the type 3 and 4 are out, because in these two cases you have the glycogen with abnormal structure. Okay, so please keep in mind, depending on the structure of the glycogen, you can quickly eliminate 3 and 4. If it says glycogen with normal structure, then 3 and 4 will be out. In type 5, what you have to remember, exercise intolerance. Along with exercise intolerance, you can also have muscle damage, which can cause myoglobinuria. Muscle damage which can cause myoglobinuria. So discolored urine or color colored urine, these terms can be there in the question. Along with the exercise intolerance, we also have what is known as second wind phenomena. So initially these individuals have exercise intolerance. When they try to do the exercise, they're not able to do the exercise for a long time. But after a short break, 2, 3, 4, 5 minutes, when they try to do the exercise, they are able to do the sustained exercise. This is called the second wind phenomena. Exercise intolerance with the second wind phenomena is characteristic feature for type 5. The exercise intolerance is also seen in a type 7, but here there is no second wind phenomena. There is no second wind phenomena in type 7. Okay, please remember, in type 5 only muscle will be enlarged, whereas in type 6 only liver will be enlarged. In type 5 only muscle, in type 6 only liver, because in type 5 it is myophosphorylase which is deficient, in type 6 it is the hepatic phosphorylase which is deficient. Okay, so I hope with the help of some of these important features, you'll be able to identify the type of glycogen storage disorder in the clinical case, and then you have to apply the information point in the table which enzyme deficiency is seen. Now very important is the effects that are seen in patients of diabetes mellitus. Now here I want to emphasize on you, when we say diabetes mellitus, what you have to understand that this is a condition with decreased insulin. See, very simple. If you have type 1 diabetes mellitus, insulin production is less. If you have type 2 diabetes mellitus, in those cases insulin resistance is there, therefore functional insulin deficiency is there. So in those cases also, for all practical purposes, the concentration of insulin is less. So whenever you get a question on diabetes mellitus, then you have to understand that we are talking about low insulin. Whenever you get a question on fasting, again the low insulin will be there. On the other hand, when you get a question on the fed state, the insulin level will be high. Okay, so please remember these points in mind. Diabetes mellitus, fasting state, insulin levels are low, whereas in the fed state the insulin level is high. In addition to that, sometimes you can get the question on glucagon insulin ratio, right? So here again you have to be very careful. Please note, when glucagon increases, sorry, it is insulin glucagon ratio, not the glucagon insulin ratio, it is the insulin glucagon ratio. I wrote it the other way around. So it should be insulin glucagon ratio. Okay, so what happens is, you know that insulin glucagon have reciprocal relationship. When the insulin level will rise, the glucagon level will fall, and obviously the ratio will fall. This means when the ratio will rise. This means when insulin rises, the ratio rises. When insulin rises, the ratio rises. On the other hand, when insulin level will fall, glucagon level will rise, the ratio will fall. So when insulin rises, the ratio rises. When insulin falls, the ratio also falls. So whenever you get the conditions of insulin glucagon ratio, you can extrapolate it to changes in insulin. Insulin rises, ratio rises. So if the question says that ratio is high, this means the insulin value is high. If the ratio is low, that means insulin value is low. Now we are dealing with a condition where insulin is low, right? Now insulin has two important functions. It activates lipoprotein lipase and it inhibits the hormone sensitive lipase. So when insulin level falls, this will become opposite. Insulin activates lipoprotein lipase, it inhibits hormone sensitive lipase. So when insulin level is less, the activity of lipoprotein lipase will be less and activity of hormone sensitive lipase will rise. So decreased action of LPL with increased action of the hormone sensitive lipase. Okay, so please remember when we say diabetes mellitus, that means insulin level is low. Whatever happens in presence of insulin, opposite will happen in cases of diabetes mellitus. So here I would like you to note the actions of insulin. Now actions of insulin are very you can say in actions of insulin, what you can say is two things to keep in mind. Number one, insulin will increase the consumption of glucose. First thing, it will increase the consumption of glucose. So whichever pathway is going to consume the glucose, those pathways will be upregulated by insulin. Second, it will decrease pathways which are generating metabolic fuel, whether it is glucose, whether it is fatty acid, whether it is ketone bodies, all these pathways will be blocked. So quick list of the pathways which consume glucose: glycolysis, HMP shunt, then glycogen synthesis, the lipid synthesis, the amino acid synthesis, and cholesterol synthesis. All these pathways will use up the glucose. So these are activated. All these pathways are activated by insulin. On the other hand, the pathways which will get down regulated: gluconeogenesis, glycogenolysis, lipolysis, and ketogenesis. In fact, when we talk about ketogenesis is actually inhibited by the action of insulin. So please note, the insulin will activate the pathways consuming glucose. It will inhibit the pathways which generate alternate metabolic fuel. And the last point to keep in mind is the insulin commonly causes phosphorylation. Not always, but most of the time it will cause phosphorylation. This means the enzymes of these pathways, insulin causes dephosphorylation. I'm so sorry. Insulin causes dephosphorylation. So enzymes of these pathways are active in dephosphorylated state, whereas enzymes from the other pathways will be inactive in dephosphorylated state. They will be inactive in the dephosphorylated state. So very commonly we get the question, which of the following enzymes is active in the phosphorylated state, which of the following enzymes is active in the dephosphorylated state. So remember, broadly insulin will cause dephosphorylation. So pathways which are activated, enzymes should be active in the dephosphorylated state, that is the action of insulin. On the other hand, enzymes which are getting inactivated in the dephosphorylated state, they will be part of pathways which are down regulated. So in this way you can remember which pathways or which enzymes are active in the phosphorylated state, which enzymes are active in the dephosphorylated state. So obviously when you talk about enzyme, you know which pathway they belong to, and now from this table you will remember which pathway is activated by insulin, therefore which pathways will be active in the dephosphorylated state and vice versa. Okay, so very important concept here. We talked about four things. See, we talked about fed state, fasting state, we talked about insulin glucagon ratio, we talked about the effects of insulin, and we also talked about enzyme activity in the phosphorylated and the dephosphorylated state. Very frequently asked topics and the questions. Okay, now one very important image, three images in this particular question if you have seen, and any of the three can land up in your exam. Most frequently which we expect is the Benedict's test. Most frequently that we expect is the Benedict test. You know, Benedict test is positive for reducing sugars, all the monosaccharides, some of the disaccharides will give the positive Benedict test. Benedict test also gives the false positive result with uric acid and the vitamin C. False positive with uric acid and ascorbic acid. So you should remember this, because Benedict test is not only for sugars, it is for all reducing substances. All right. Second is the Rothera's test. It is for the ketone bodies. Which are the ketone bodies? You know, the three ketone bodies are acetoacetate, acetone, and the beta hydroxybutyrate. But here you have to remember that beta hydroxybutyrate is actually a pseudo ketone. It doesn't have the keto group. Therefore, beta hydroxybutyrate will not give the Rothera's test. Please remember this point. Rothera's test will not be given by the beta hydroxybutyrate. Acetoacetate and acetone have the keto group, so they will give the positive Rothera's test. Rothera's test is also known as the modified nitroprusside test, which is for the ketone bodies. The third test is what is known as the heat coagulation test, and this is performed for proteins. It can also detect phosphate, but by adding the glacial acetic acid we can confirm whether the protein is there or the phosphate is there. So there are three important image based tests which can be there. Instead of heat coagulation test, they can give you the biuret test. I don't have the image for biuret test. It has the purple color on a positive result, so light purple and dark purple can be there in the image. So dark purple will indicate that positive biuret test is there. The biuret test is also for proteins. Okay, so these are the common images which can be given on testing of the urine. All these tests commonly performed in the urine. Okay, so please remember this. Now we had said previously, in starvation also you are going to get the ketoacidosis. There are three causes for ketoacidosis. One was the diabetic ketoacidosis, second was the starvation, and third was the alcohol intoxication. All of these are going to cause the ketoacidosis, right? So here the question mentions the prolonged starvation is there, so obviously the Rothera's test is going to be positive. Now when the prolonged starvation is there, the glucose levels are likely to be on the lower side, so the Benedict test will not be positive, so one cannot be there. Similarly, because nothing else is mentioned about any kidney damage, the protein in the urine will not be available. Only the Rothera's test will come out to be positive. If it mentioned a case of diabetic ketoacidosis, in that case you will have both 1 and 2, Benedict test for blood glucose, and you can have the Rothera's test. If it says a patient of chronic diabetes coming to you in case with the presentation of the ketoacidosis, in that case all three will be there. If patient of chronic diabetes is there, then there will be the chronic kidney disease, right? In that case the protein will also start coming out in the urine. You know that the albuminuria will be there, macroalbuminuria will be there in patients of the chronic diabetic patients where the chronic kidney disease has set in. Okay, so different scenarios, based on that the different result can be there. In starvation, only ketone bodies. Okay, if a patient of diabetic ketoacidosis, only that is mentioned, then ketone bodies plus the glucose. If it mentions a patient of diabetes where the chronic kidney disease is present, has now landed up in diabetic ketoacidosis, then all three, protein will also be there, the ketone body will also be there, and glucose will also be there in the urine. For the protein, you can either have the heat coagulation test in the image, or you can have the biuret test, where in the test tube the homogeneous purple color, light purple and dark purple color will be seen. I don't have it on this slide, so I'm not able to show it to you. Okay, so very important colored images performed in the urine on a routine basis. Nowadays we generally don't perform the Benedict and the Rothera's test, because the glucose estimation in the urine and the ketone body estimation can be done on the paper strip. You can either have the multi-sticks can detect 11 to 13 different analytes, or you can have the heuristic detects only the glucose and the protein. Okay, so normally we just do the dip test. The urine is used as a sample, the paper is dipped into it, and we allow the color formation to happen, and then we compare with the standard reference charts. Okay, another important question, very important, is the inhibitor of cytochrome C oxidase. See, we have 4 complexes, complex 1, 2, 3 and 4. Nowadays we don't get the question where the number of the complexes is given. It is the name of the complex which is provided. So you should also know the names of the complexes. Complex 1 is known as NADH Q oxidoreductase. Here the Q stands for ubiquinone. So instead of Q, they can also write ubiquinone. The 2 stands for the succinate Q reductase. 3 stands for Q cytochrome C oxidoreductase. And 4 is cytochrome C oxidase. So please keep the names in mind. Please keep these names in mind. A lot of time nowadays when we get the question on electron transport chain, they will not write the numbers, they will write the names of the complexes. They will write the names of the complexes, and you should remember that. Okay. Most commonly we'll get the question focused on complex 4. Most commonly we'll get the question focused on complex 4. So one name which you should remember is the cytochrome C oxidase, also known as complex 4. Here there should be no confusion. Please keep in mind complex 4, also known as the cytochrome C oxidase, inhibited by carbon monoxide, cyanide, hydrogen sulfide and azide, the 4 common inhibitors of the cytochrome C oxidase. Nitric oxide is a second messenger acting as vasodilator released by the endothelium of the capillaries from arginine by the action of nitric oxide synthase. It is not a cytochrome C oxidase inhibitor. Okay, so please remember these 4 names: hydrogen sulfide, carbon monoxide, cyanide and azide. 2 important clinical scenarios should also be known to you. Hydrogen sulfide, where you will normally find hydrogen sulfide in your surroundings where the poisoning can happen. Okay, the hydrogen sulfide builds up in sewer lines. So if worker entering for the maintenance or the cleaning of the sewer lines, there you can have the buildup of hydrogen sulfide and it can cause death. Carbon monoxide builds up in closed room with burning fuel. So recently we had this very unfortunate incident in Shimla in this winter only, that during the rush to see the snow, when there was a lot of crowding in Shimla, one of the drivers didn't find any room in the dormitory. So what he did, that he lit up angithi in his car to keep the car hot, and went to sleep in the car only. In the morning, the car, the windows had to be broken down, the door had to be opened up to take out the driver, but unfortunately the driver had passed away due to buildup of carbon monoxide and the poisoning which happened due to the carbon monoxide. So buildup of carbon monoxide will happen in closed room or closed places where the burning fuel has been left. Alright, and hydrogen sulfide buildup will happen in the sewer lines. It can again cause death of the workers who go inside the sewer lines to do the manual cleaning. So these 2 clinical scenarios, please keep that in mind when they are mentioned. Then you have to think about these 2 components and causing the inhibition of complex 4, that is the cytochrome C oxidase. Okay, another very commonly asked question is the mechanism of reversible inhibition as seen in the Lineweaver-Burke plot. These 2 plots are example of Lineweaver-Burke plot. The Lineweaver-Burke plot is also commonly known as the double reciprocal plot. Also commonly known as double reciprocal plot. Why double reciprocal plot? See, on the x-axis you have reciprocal of substrate concentration, 1 upon substrate concentration. On y-axis you have the reciprocal of velocity, 1 upon velocity. That is why it is also known as the double reciprocal plot. On both the axes you have the reciprocal values. On both the axes you have reciprocal values, so we call it the double reciprocal plot, commonly used to compare between the different types of the reversible inhibition. Okay, now the blue one in this case is showing a line where the inhibitor is not present. Okay, no inhibitor, that is the blue line. You can see no inhibitor, that is the blue line. Now one important point you have to remember when you're looking at the Lineweaver plot, the point where it crosses the y-axis is 1 upon Vmax, whereas the point where it crosses the x-axis is minus 1 upon Km. Okay, so if you know these two values, then it is very easy to identify the different types of inhibition as seen on the Lineweaver plot. I'm sure all of you already know that when we talk about the competitive inhibition, the Vmax is normal, whereas when you talk about the non-competitive inhibition, by definition the Km is normal. These two values are known to you. If you remember just these 2 points when you talk about the enzyme inhibition, if you remember just these 2 points, that in competitive inhibition the Vmax remains normal, in non-competitive inhibition the Km remains normal, then it is very easy to identify these graphs. See, in the first scenario, the two graphs have the common point on the y-axis, and we said the point on the y-axis is the 1 upon Vmax. This means graph 1 and graph 2 have the same 1 upon Vmax, meaning they have the same Vmax also, and Vmax is normal in competitive inhibition. So the first scenario must be the competitive inhibition. The first scenario must be competitive inhibition. Looking at the second graph, they have the common point on the x-axis. X-axis is minus 1 upon Km. This means graph 1 and graph 2 have the same 1 upon minus 1 upon Km. This means they have the same Km, and Km is the same in non-competitive inhibition. So just by remembering what does not change, you are able to very quickly identify the type of inhibition. You are able to identify the type of inhibition on the Lineweaver plot, also known as the double reciprocal plot. The Lineweaver plot, also known as the double reciprocal plot. Please don't forget this name. Sometimes in the question, instead of the Lineweaver plot, they can use the term the double reciprocal plot. You also have something known as single reciprocal plot. Sometimes in the question you can just get one liner question, which of them is the single reciprocal plot. So just remember the names: Eddie-Hofstee and Hannes-Wolff. Eddie-Hofstee plot and the Hannes-Wolff plot, these are examples of the single reciprocal plot. These are examples of the single reciprocal plot. Sometimes you can get one liner questions about which of the following is single reciprocal plot. We use them when there is clustering on Lineweaver plot, because when there is clustering on Lineweaver plot, the comparison between the different reactions becomes very difficult. In those cases we have to make use of the single reciprocal plot. Okay, so this is showing the different types of inhibition, how they appear on the Lineweaver plot, what are the effects on the Km and the Vmax. Now this metabolic syndrome has now become very important. You know that India is emerging as the hotspot for the metabolic syndrome. Already we have been declared as the capital of diabetes, and the metabolic syndrome is exploding like anything. So please make note of the components in the metabolic syndrome. So first, waist circumference over 40 inches for men and 35 inches for women. The blood pressure over 130 by 85 millimeter of mercury. The TG level over 150 milligram per deciliter. The HDL level less than 14 men and less than 15 women. And fasting blood sugar level over 100 milligram person. Okay, so what you can see here from the question, the hip circumference is not asked, it is the waist circumference. Okay, so we're not looking at the WHR, the waist hip ratio. So hip circumference is not a part of the metabolic syndrome definition. So please remember these 5 points about the metabolic syndrome becomes very important in the current scenario, where the metabolic syndrome is coming up as a very big problem, and there is talk of now sensitizing the population also, that they should think about obesity as a disease, not just a lifestyle thing, and seek treatment for the same. So here the HDL, glucose, hypertension are part of the metabolic syndrome diagnosis, but not the hip circumference, rather it is the waist circumference which has to be kept in mind. Another very commonly repeated question is the Gaucher's disease. I am sure all of you know that crumpled, or sometimes written as wrinkled, tissue paper appearance. Crumpled or wrinkled tissue paper appearance. Sometimes the text may be given or the image can be provided. The text or the image can be provided. So to keep in mind the crumpled or wrinkled tissue paper appearance, immediately you should think about the Gaucher's disease. The beta glucocerebrosidase is the deficient enzyme in Gaucher's, and very commonly repeated question, simply because it is the most common lysosomal storage disorder. Most common lysosomal storage disorder commonly presents with either the abdominal pain, or in some cases it can present with bone pain. We call it the bone crisis. When the bone pain is there, we call it the bone crisis. And there will be the accumulation of typically you see this Gaucher cell in the bone marrow biopsy. They can mention the triphenyl biopsy is done or the bone marrow biopsy is done, and then you find the crumpled or wrinkled tissue paper appearance, that is the Gaucher cell. Please keep in mind about the term that is called pseudo Gaucher cell, which is seen in chronic myelogenous leukemia. Appearance exactly that of the Gaucher cell. That is why Gaucher cell is not diagnostic for Gaucher disease, because you also have something called pseudo Gaucher cell, which can be seen in chronic myelogenous leukemia, also presents with hepatosplenomegaly and abdominal pain. So in that case also you have to do the bone marrow biopsy to identify the cause for the clinical presentation. So overlapping clinical presentation can be there, and that is why just the presence of Gaucher cell is not diagnostic. The presence of Gaucher cell is not diagnostic. It is a strong indicator. It is a strong indicator for Gaucher disease, but not confirmatory for the Gaucher disease. In Gaucher disease, you should also keep in mind that ACE, TRAP, and chitotriosidase are simultaneously elevated. These three enzymes are simultaneously elevated in patient of the Gaucher disease, which is a strong indicator for the Gauchers. ACE, TRAP, and chitotriosidase. Repeatedly we are getting the question on Zellweger's. So in Zellweger's you have to understand that the problem is in the peroxisome. Peroxisome is either absent or it is empty, resulting in the accumulation of very long chain fatty acid, most commonly in the CNS, but also in the liver and kidney, because of which the condition is known as cerebrohepatorenal syndrome. All of these are questions, by the way. All of these are questions. First was, Zellweger syndrome is caused due to defect in which peroxisome? Peroxisome may be absent or it may be empty. What accumulates? There is accumulation of the VLCFA, most commonly accumulates at CNS. The other name for the Zellweger syndrome is the cerebrohepatorenal syndrome. Each of these has been asked as a question. Enzyme deficiency in Gaucher's, it is the beta glucocerebrosidase. Okay, beta glucocerebrosidase is the deficient enzyme. Okay, So Zellweger's is very frequently asked. Sometimes along with Zellweger you can get the question on Refsum's disease. Okay, in Refsum disease, the defective metabolism of phytanic acid. Phytanic acid is the branched fatty acid. Okay, so when you see the question mentioning phytanic acid and accumulation of phytanic acid, immediately you should think about the Refsum disease. There are other additional features also. I'll not go there because the phytanic acid is the characteristic accumulating substance in case of the Refsum disease. So as soon as you see the accumulation of phytanic acid, immediately you go for the Refsum disease. The metabolism of the branched fatty acid also occurs in the peroxisome only. So in both the cases the problem is in the peroxisome. In case of Refsum's, only one enzyme is deficient. In the Zellweger, the whole peroxisome is deficient. Okay, then coming back to the ketone bodies, the ketone bodies are synthesized by liver, but liver is not able to metabolize the peroxisome because the enzyme required for activation, also known as succinyl coenzyme A, acetoacetate coenzyme transferase, means this enzyme is going to transfer the coenzyme from succinyl coenzyme to acetoacetate. That is why we call it the succinyl coenzyme acetoacetate coenzyme transferase. The common name for this enzyme is thiophorase. The common name for this enzyme is thiophorase. Okay, so please remember that all tissues except liver and RBC, all tissues are able to metabolize ketone bodies, including the CNS. Only these two tissues are not able to metabolize. Liver because it doesn't have the thiophorase, RBC because it doesn't have the mitochondria. Alright, so remember about ketone body. We already said that ketone body can be tested by the Rothera's test, where the beta hydroxybutyrate will not give the positive result. Production occurs exclusively in the liver within the mitochondria. Okay, so another common question is about the inherited hypercholesterolemia. So here you can see the list is quite big, but the ones which you have to remember are type 1 and type 2. These are the two which are likely to land up in your exam. In type 1 we get to see lipoprotein lipase deficiency. Lipoprotein lipase deficiency can be due to three reasons. First, gene defect of lipoprotein lipase. Second, transport defect of LPL, and third, the LPL is activated by ApoC2. So if there is ApoC2 gene defect, then also you'll get the functional lipoprotein lipase deficiency. So please remember, lipoprotein lipase deficiency can be either due to gene defect, due to transport defect, or due to the ApoC2 defect. The lipoprotein lipase will primarily metabolize the chylomicron. The lipoprotein lipase also acts on the VLDL, but that metabolism is slower. Fast metabolism of chylomicron after the meals happen. Okay, so when there is deficiency, the chylomicron cannot be cleared efficiently, and when you take the sample after 8 to 10 hours post meal, the chylomicron is still there in the circulation, and main content in the chylomicron is the triacylglycerol. So the triacylglycerol levels will be elevated. Okay, so this is one. In these patients, what you get to see is the cutaneous or the subcutaneous xanthomas. In the question they will mention cutaneous or subcutaneous xanthomas, and the triglycerol levels are high. On the electrophoresis, the chylomicron segment is found to be increased. Okay, so these will be the features in lipoprotein lipase deficiency. Second is the familial hypercholesterolemia, familial hypercholesterolemia, or the condition where LDL level is high. In these cases they can be mentioned of family history of cardiac disease, so that part can be mentioned, and very commonly it is due to the LDL receptor deficiency. Please note that it can also be due to the ApoB100 mutation, although this is rare, but it can also be due to the ApoB100 mutation. LDL is elevated. Main component in LDL is the cholesterol, and in these patients what you get to see is the tendinous xanthomas. So if the question mentions accumulation of the fat or the xanthoma over the Achilles tendon, whenever they mention tendinous xanthoma, then you talk about type 2A. They will also give the family history of cardiac events. So again, that is another indicator for familial hypercholesterolemia or the elevated LDL levels. One more important question about the special products of the amino acids. So here you have to know about the products coming out from the amino acids. So what I've done, the notes, the slides that you've got, it has the list of the special products and from which amino acids they are coming. For example, glucose coming from all amino acids except lysine and leucine. The creatine synthesized with the help of arginine, glycine and methionine. These three are required for the synthesis of creatine. Nitric oxide synthesized from the arginine. The purine ring requires glycine. The histamine produced from histidine by decarboxylation. Similarly, the glutamate generating the GABA again by decarboxylation. And the catecholamines, the thyroxine hormones, melanin coming from tyrosine, the serotonin, melatonin and niacin coming from tryptophan. Here please create the rhyme serotonin plus melatonin, please create that rhyme, because frequently we get confused between melatonin and melanin. So if you remember serotonin, melatonin together, then you will remember that it is coming from tryptophan and there will be no scope for confusion. Remember, serotonin, melatonin both from tryptophan. Coming back to the table, this table is actually matched correctly. Already it is matched correctly. So the cysteine involved in taurine formation, glycine involved in creatine formation, tryptophan for melatonin and tyrosine for the thyroid hormones. For creatine, you have to remember that in addition to glycine, it also requires arginine and methionine. Okay, right, so please go through this very small simple table which is there and remember the names which are highlighted. The breakdown of heme is probably the only physiological reaction where the carbon monoxide is physiologically produced. Okay, that is why this reaction is important. Heme breaks down into biliverdin, releases the ferric iron and carbon monoxide is produced. When we produce the heme during synthesis, we actually use the ferrous iron. That is why this ferrous part becomes important. During synthesis we require the ferrous iron, but when you do the breakdown, at that point it is the ferric iron which is being released. So remember, ferric iron, biliverdin, carbon monoxide, they are the ones which are produced on the degradation of heme. Amino levulinic acid is the first intermediate in heme synthesis. It is the first intermediate in heme synthesis. All right, now this wobble hypothesis, wobble phenomena, wobble site, these terms are commonly asked in the exam. So first, what is wobble hypothesis? Position 3 of codon and position 1 of anticodon. they have flexibility in pairing. What does this mean, flexibility in pairing? Normally whenever there is pairing, and the Chargaff rule has to be followed, but here they may or may not follow the Chargaff rule. This is the wobble hypothesis or the wobble phenomena. And the wobble site is actually the position 1 of anticodon. So same nucleotide on position 1 can pair up with two different nucleotides on position 3 of the codon. So wobble site is one question. You have to remember, wobble site is position 1 of anticodon. Wobble phenomena, that is flexibility in pairing. It may pair as per Chargaff rule, it may not pair as per Chargaff rule. This is the wobble phenomena, and this wobble phenomena is responsible for degeneracy and also for what is known as silent mutation. Degeneracy means more than one codon for same amino acid. So different nucleotides are corresponding to the different codons are corresponding to the same amino acid. All right, and that is because the corresponding tRNA will identify the two different codons for the same amino acid. That is how the wobbling is happening, and this is responsible for the degeneracy. Okay, so wobble hypothesis is responsible for degeneracy as well as it is responsible for the silent mutation. Two very commonly asked questions in terms of the wobble phenomena. We also had question on which of the two is the wobble site. Wobble site is position 1 of anticodon. Very important conceptual question from epigenetics. Here I'll just tell you two things. Please make note and remember very clearly. First, DNA methylation. What will happen? DNA methylation, what will happen? Decreased gene expression. Second, histone acetylation. What will happen? Increased gene expression. Please remember these two things. So DNA methylation, decreased gene expression. Histone acetylation, increased gene expression. Now this methylation typically happens within the CPG islands. CPG islands happen to be what are known as enhancers. So these are additional terms which you have to keep in mind, that methylation happens in CPG islands which are enhancers. So when you do the methylation, the enhancer effect is suppressed and therefore gene expression is suppressed. On the other hand, histone acetylation facilitates you can say uncondensation of the chromatin structure, and therefore gene expression happens faster. These two are very well documented effects of epigenetic changes. These two are the very well documented effects of epigenetic changes. So here what is the question saying? Question says that there is increased expression of TNF alpha. Now we're talking about increased gene expression, right? So when you do methylation, what will happen? On methylation, expression will decrease. On methylation, the expression will decrease. Similarly, when you do the deacetylation, expression will decrease. When you inhibit acetylation, expression will decrease. But when you are doing the prevention of methylation is going to cause inhibition, but you're preventing the methylation. In that case, the expression is likely to increase. Okay, so remember these two terms. When we are talking about DNA methylation, always decrease in gene expression. When we are talking about histone acetylation, always increase in gene expression. This question is being asked again and again. What are the effect of the different epigenetic changes? The two which you have to remember are only methylation and histone acetylation. There are a lot of other changes happening in the histone, but their effects are variable. However, the effect of acetylation is fixed and it is always going to cause increase in gene expression. Diphtheria toxin is the favorite of the examiners. However, this time we are likely to get a different one, but let's first look at diphtheria toxin and then I will talk about the second possible or probable toxin which might land up in our exam. Okay, so EF2 toxin, the diphtheria toxin, all are true except diphtheria toxin is actually acting on the elongation factor 2. That is why it is also known as the EF2 toxin. It is an exotoxin. I'm sure you know what is an exotoxin. Exotoxin is a toxin which is released by the organism while it is still living. It is released in the surroundings, and it is produced by the bacteria only in the lysogenic phage. The bacteria which is involved here is Corynebacterium diphtheriae, right? So this tox gene, the tox gene is present on the phage. It is a gene of the phage, not of the bacteria. So you must have the lysogenic phage before the toxin can be produced. However, it is not the most lethal toxin. The most lethal toxin name actually in terms of chemical agent goes to what is known as ricin. Fatal in milligrams. Fatal in milligrams obtained from castor bean. Inactivates the 28S ribosomal RNA, causes the glycolytic cleavage of the adenine. Ricin becomes very important because recently during one of the police actions from terrorist module in Delhi NCR region, 2 liters of castor oil and ricin were extracted, which was part of a very big you can say terrorist activity, and because of this ricin is more likely to land up in your exam. For the last 2-3 exams they've been asking the diphtheria toxin, but I am expecting that ricin will land up in your exam this time. It was very much highlighted in the newspapers. Okay, so please keep in mind ricin. How is it acting? It is inactivating 28S ribosomal RNA, which is the peptidyl transferase. Means it is a ribozyme, and RNA acting as enzyme, that is ribozyme. RNA acting as enzyme is the ribozyme, the 28S ribosomal RNA acting as peptidyl transferase in translation. Okay, how many more questions do we have? Let's see. Okay, I think this is the last question, and that is steps of PCR. PCR, the polymerase chain reaction, is one of the very important questions for your exam. Please don't mix up the sequence of steps of the PCR. The very simplistic question which is there, what are the steps in sequence of PCR? So first you separate the strands. Then you allow primer to attach, that's annealing, and then you extend the primer, that is extension, also known as elongation. These are the 3 primary steps of polymerase chain reaction. Prerequisite for doing the polymerase chain reaction is design and synthesis of primer. Sometimes this is known as step 0. These 3 steps make up one cycle. 30 to 40 such cycles, followed by a final elongation step. This final elongation step is longer than normal, and then you visualize results with DNA gel electrophoresis. You visualize the results with DNA gel electrophoresis. Okay, so about PCR I'll not go into too much detail because we don't have so much time, but remember the steps in sequence are very important, and what is happening in each of the step, that you should know. The denaturation typically happens at 90 to 94 degrees Celsius. the annealing happens between 45 to 65 degrees Celsius, and extension happens at 72 degrees Celsius when you are using the enzyme Taq polymerase. Before I close the question on the polymerase chain reaction, I'll just like to mention the substrates required for the polymerase chain reaction. Another common and important question coming from PCR. So here you have to remember, first is the template DNA, which comes from the patient sample. Rest will provide from lab. The template DNA will come from the patient sample. Then you have the enzyme, that is the Taq polymerase. Then you have to provide the primers, always in pairs, and you have to provide the building blocks. The magnesium is the cofactor. Magnesium is not available, you can even use manganese. And lastly, the buffer to make sure the pH is maintained during the reaction. So please note, the only variable is the patient sample. If the template DNA is present in the patient sample, then the PCR will be successful. Yes, magnesium is required. If magnesium is not there, then you can replace with manganese. If the patient sample doesn't contain the template DNA, PCR will not be successful. There are variants of PCR. For example, the real time, also known as the quantitative PCR. You have what is known as multiplex PCR. You have what is known as isothermal PCR, and sometimes you can combine the PCR with what is known as reverse transcription. When your starting material is RNA, then before you can do the polymerase chain reaction, you have to convert it to complementary DNA. The whole process will be known as RT-PCR. Please note, real-time PCR is not known as RT-PCR. RT-PCR means reverse transcription followed by the polymerase chain reaction. Okay, the real-time PCR will be known as qPCR. Okay, so these are some important terms related to PCR. Yes, we also have what is known as nested PCR. About multiplex PCR, you should remember that it is used in the diagnosis of meningitis. See, in meningitis we have 3-4 common causes for meningitis, so you can detect for each of those 3-4 causes simultaneously in the same reaction. So that is what we call as multiplex. See, we have the multiplex PVR. When you go to PVR, there are multiple halls in the same complex. So similarly, when you're testing for different targets within the same reaction, we call it the multiplex PCR. You can just remember and contrast with PVR. In the multiplex PVR, you have multiple screens. So similarly, in multiplex PCR, in the same tube, we are testing for multiple targets, and commonly used in the diagnosis of meningitis, symptomatic or syndromic diagnosis of meningitis, where we are commonly using the multiplex PCR. We use the multiplex PCR during the COVID pandemic also. So in our COVID pandemic, we had the QRT PCR, which was the multiplex type. Okay, so this is where I will stop. Thank you for those who stayed connected. Thank you for having the patience for staying connected for 2 hours after the delay of almost 1.5 hours that we had due to the glitch. I ran quickly to the studio so that we could have this session, and thank you very much and best of luck for your exam. I'll close the session here. If you have any doubts or any queries, please feel free to drop me a message on my WhatsApp. I'll be happy to respond. So that's all from my side. Thank you very much. Take care. Bye bye. Good night and best of luck.